So good morning. So let's start our session with this first case of 33-year-old female pregnant patient, about 30 weeks gestation, presented with some vaginal bleeding. MRI was requested for her. Just 1 second, Doctor. Okay, continue. So what do you think is going, just give me 1 second, I will, to make it around 30, something like that. Okay.
MRI of the obstetric MRI.
Okay, obstetric MRI or MRI of pregnant uterus, for example.
Yes.
Gravid uterus.
Sagittal image T2.
Okay,
Without fat cell.
amazing, good introduction, very nice.
Showing cephalic presentation of the fetus.
Mhm. بدينا نبسبس بعدنا first case. So first of all, what do you notice in this sequence? There is a motion artifact.
Yes.
Why there is a motion artifact?
So baby is
Due to fetal movement.
Yes.
Okay,
The placenta is low lying.
low lying, which means it's placenta
previa.
previa. And
Closing the.
شفتي, did you see the highlights in radiology last episode?
No.
دا
No والله.
والله تستاهلين العد.
ما كان عندي مجال.
تستاهلين ما عندش مجال؟
لا يعني ما كان عندي
ما عند يعني 20 minutes ما عندش مجال هيك بيزي انت لهالدرجه يعني؟ زين.
تعودنا على السد
مو حسب التوبيك. It's anywhere between 10 to 30 minutes, something like that. So anyway, we need to do fast imaging sequences due to because of the fetal movement. We have special sequences that are very fast. It's like 10 or 15 second the sequence first. And whenever we see placenta previa, like in this case, we should suspect what?
accreta.
Accurate. So let's see.
This is corona.
Okay.
MRI. Fat spin echo. Showing that low lying placenta.
Mm-hmm.
The line is present there, but
What line?
biomaterial,
Mm-hmm.
but it's absent there. يعني
Miran, how many layers the myometrium have?
3 years.
3 layers, which are on
High, low.
exactly hypointense, hyperintense, hypointense. This is the gravid uterus I'm talking about.
yes.
Mm.
No hydrocephalus of the baby. Spine looks normal.
Okay, the baby looks normal, the fetus.
دكتور ممكن هذا نشيله يعني حتى نشوف.
I have to pay money. You can't do like this.
The bladder wall is intact.
Do you judge the bladder wall on T1 weighted images? On T2. And you started with T2 fat saturated images. بالبداية كانت فوق. Yeah, the first one. منو شاف الابيسود؟ highlights. يلا tell me the findings.
The bladder wall, upper bladder wall shows irregularity, not smooth like other sides. of
Good.
the-
First. Second,
Yes. And the placenta is low lying.
low lying previa.
Covering the os. So previa, we should suspect the accreta.
عافية.
And the myometrium at site of placental attachment is invaded by the
Let's
placenta.
give me the mouse, please. Let's help your friend. So if we do something like this, for example, magnify on this part, you can see some myometrium here, صح?
Yes.
Yes.
But do you see any here?
No.
So it's not present at this part. And you can see let's go to the T2 fatsat. Of course, there is a motion artifact, I know. But however, the placenta is well seen and you don't see any distinct myometrium here, right? And what else? What about the vascularity?
Increased.
There is a lot of flow voids, more than normal. And what about the shape of the placenta? Is it smooth or bulky? The edges are rounded and bulky. Okay, so all of these together, and of course here would be the site of a previous cesarean section. Somewhere it should be around here, which we don't have a myometrium. Let's see here. This is coronal, but okay, it will do the trick. You can see here, the placenta is not definitely separated from the bladder. And if we go to the axial, again, you will see the fetal brain is within normal limit, but you can see here areas of loss of the myometrium, like here. Where's the myometrium here? Let's do it like that. You can't see any, and you have marked flow voids. So all of these are in favor of what?
Placenta acrita.
Pericrita.
Yes.
And is it important to differentiate placenta acrita from incrita? مهم إنه نقول هذه acrita لو incrita? Is it important?
بس ما نقدر.
No, you can suggest,
The
but
line of treatment is same.
acrita from incrita has the same treatment, so we don't waste our time differentiating whether this is acrita or incrita. Is it important to differentiate acrita from pericrita?
Yes.
It's very important because the treatment will be completely different. Pericrita will need maybe Eurosurgery available or GI surgery available or whatever, depending on the invasion. While acrita, it's purely gynecological problem. So this is what type? Acrital or incrital or pericrita?
I know pericrita.
It's definitely pericrita. Okay?
Yes.
So this,
Percurrent.
I know, but she should be more يعني شو نقول in this يعني ال PER it's life and death for the patient, the pericrita from acrita.
بس والله صعب يعني decision on شو اسمه.
It's difficult, but this is the final شو نقول بالضبط the final test, nothing else. Okay, should we give contrast?
No.
No, pregnant. Blood-brain barrier because of.
Because it will be the contrast of MRI is teratogenic, so you don't do an MRI with contrast except in cases where the fetus is decided for abortion for any reason. If they are deciding the abortion, okay, give contrast, no problem. But you should have confirmation from the gynecologist and from the patient and from the husband that this is an abortion case, and you should explain to them that the contrast is teratogenic if there is indication for contrast. If there is no indication, no need. Okay?
But here, and they send it at any time.
Well, you have to work with what you have. Yani if they send it at 35 weeks, what would you say? No, I won't do it. You have to, and you try. If you see definite signs of placental invasion, definite, you report it. If you cannot decide whether this is any acrita spectrum or not, you describe what you see, and then you write at the end of the report, placenta acrita could not be excluded. I did what I can't exclude it. because due to advanced gestational age, for example, or early gestational age. We need to do it again after a few weeks. Okay? But if you see definite signs, like placenta extending into bladder or bowel or whatever, then you just write findings are indicative of placenta accreta or increta or pericrita. Well, we usually say accreta and pericrita. We don't say increta, usually. Okay. Maria. شلونك؟ Easy. Nothing to be worried about. It's شنو؟ سير؟ لا 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 بعد دورة والله. لا والله it's so straightforward. This is a 32-year-old male patient presented with headaches, visual disturbances, things like that. بلا بس ترى اللي بس راح يقوم وراها، لا تقولوا ما قال لنا.
جربنا عادي تعودنا.
مو بس اهدد غير شو اسوي عاد. First of all, we start with T2 axial. Wait.
AG
32 years old, male patient. شلون هالجمعية؟ زينة؟ The representative of the Radiologist Society is here with us. That's big deal.
axial T2.
Welcome,
brain.
welcome.
Heterogeneous lesion seen in the suprasellar region.
Okay. So this is a T2 weighted axial. شنو هذا السيكونس؟
T1 post contrast.
So you got immediately to post contrast before you see the pre contrast? You don't go to post contrast. You see the T1 and the T2 and the flare and the I don't know what, and then you go to the post contrast. What's the lesion? Describe the lesion here. What do you see?
Iso-intense lesion, homogeneous.
First of all, what's the sequence?
T1 falsat.
T1 fat sat sagittal. Good.
Well defined of homogeneous.
Ill well defined. Sorry, ما اسمع. بس please be quiet. شنو؟
Ill defined.
Ill defined. So if you إذا أنت رسمتي وأنا رسمته, if you draw it and I draw it, will it be different? يعني if you come, I told you, just please draw the lesion, you will draw something like this, right?
Yes.
And then I come and draw the lesion, I will draw something like this. Our lines will match or they will be different? They will match because the line is very clearly defined. أكثر من هذا. So it's not ill-defined, it's well-defined, because when you say ill-defined, you are talking of either infection or malignant, most likely. When you say well, most likely, not always. When you say well-defined, we are talking mostly about something benign, صح?
Is the inferior part clear?
Mm-hmm. Clearly not. This, all of this is the inferior part. I think so. If you have any other, let's say, perspective on that. So, let's start from the beginning.
Yes.
Wait, let me help you. to make it more. So we have T1 and T2 sagittal images of the brain showing what?
Well-defined homogeneous lesion seen in the cellar and supracellular region.
Good.
Iso-intense in T1.
Okay. And
In T2. Same.
maybe slightly hyperintense or even iso-intense. Doesn't matter that much. So this lesion, is it invading anything?
No.
Okay, it's not invading. Is it expansile?
Yes, expansile lesion.
Expansile of what? What does it expand? Expands? I don't know. What does it expand?
Expanded cellar. Cellar.
The cella torsica is expanded. Excellent. And it's passing into the supracellular system.
Yes.
So, what would you do next?
Contrast
Why?
for enhancement and invasion of the surrounding.
Enhancement, if it enhances or does it enhance? What's the difference? شوف ركلج. If this lesion enhanced or it does not enhance, does it make any difference to you?
Yes.
Why?
Cystic lesion don't enhance.
Is this cystic?
No.
You don't need contrast to say this is soft tissue, not cystic. You have all you need is T1 and T2, that's it. So the enhancement of the lesion itself is not necessary or not, it will not provide an important diagnostic information. What's important here is to detect any encasement or invasion. Invasion or encasement of the surrounding lesion, it will determine the course of treatment. If it is encasing or invading something, the surgical approach will be much harder than if it is not encasing or invading. Okay? But the enhancement of the lesion itself, what difference does it make if it enhanced or not enhanced? Nothing. Okay? So, we gave contrast and wait a minute, let me help you. And we have this and this post-contrast images.
Enhanced.
So, and again we said the lesion, if enhanced or not, it's of no difference to me. I don't care. What I care is
For invasion.
invasion. And where do I see the invasion better? On axial or coronal? Coronal. So let's magnify a little bit. And what do we need to see invasion of what?
Circle of what? Or cavernous sinus.
First cavernous sinus, which basically means the internal carotid artery in the cavernous sinus. And second, where else? That's important to detect if it's encased or invaded or not.
Nerve.
What nerve?
Oculomotor.
Oculomotor. طلعي لي oculomotor ده شوف شو راح تلاقيه.
Optic nerve.
Optic chiasm.
Yes. Yes. Opticism.
Optic chiasm.
Yes.
Okay? These are the major structures that we need to look for any signs of invasion or encasement or whatever. Okay? Yeah, راوينس. Show me. What is the cavernous and the internal carotid artery? This one and this one. Are they encased?
No.
Wallah? Are you sure? Wait. Let me help you even more. Yeah. Wait. Look at this image.
Encased.
The right side is definitely encased. There is an enhancing soft tissue extension of the lesion around the right ICA, this will change the surgical, it will change everything. هذا ما كان surgical يصير medical. You cannot remove the ICA. Okay? High first. Second, this side, probably yes, probably no. There is some little bit enhancement, I'm not sure. But the right side is definitely encased. And what about the other thing, which is the optic chiasm? Let's see. Do we have any signs of involvement of the optic chiasm? We have coronal and sagittal. Whatever you like, we can provide.
Yes.
So, it's basically more of a compressed rather than, in order to say it's encased, we need to see the lesion on both sides of the nerve. And here we see the lesion only here and not on the other side. So basically it's compressed. Whether it's invaded or not, we cannot say with very high certainty, right? So, the important thing here is to mention that the right ICA is encased because it will change all the management. So, summarize your finding. Give me your report.
pituitary
Findings.
finding.
تقرير مالتي. Just tell me what will you write in your report.
Well-defined homogeneous lesion seen in the cell and extending to the suprasellar region,
Okay.
enhancing, encasing right cavernous sinus, right ethnocardiac artery,
Good.
compressing optic chiasm,
Good.
suggestive of
So what's your differential diagnosis?
pituitary adenoma,
Pituitary.
adenoma,
بس أدينوما؟
cranial, بس craniopharyngeal adenoma,
يعني هذه نقول عليه pituitary adenoma ولا نقول عليه pituitary macro
macro
adenoma.
adenoma.
That's different. Adenoma ممكن micro adenoma ممكن macro. So what if this is pituitary macro adenoma? What hormone do you think he has elevated? Prolactin, growth hormone, TSH. What hormone is, because it's pituitary?
Prolactin.
Why? ليش قلتي prolactin? What did you see that suggests this is a prolactinoma? شو تقولين؟ What hormone is elevated in this patient? Aldosterone هنا يقول. أنت شو تقولين؟ I'm not saying wrong. هنا يقول aldosterone، هنا تقول prolactin. What do you say? Hozan.
If it's bright vasopressin, if not bright, any other hormones.
Miran. No idea. To be honest, هي طبعا all of your answers are wrong, but the best one is Miran. Why? Pituitary macroadenomas are non-functional. He has no hormone elevated. لو كانت functional, if it was functional, راح تكون microadenoma. We detect microadenoma due to increased hormone. If he has prolactin, he will be lactating, or she will be lactating. If he has, I don't know, growth hormone adenoma, he will be giantism and acromegaly and things like that. If because they are so small, but they are functional. If it is non-functional tumor, it does not excrete, he will have normal body, normal hormones. And when the tumor gets big and starts causing mass effect and compression on the optic nerve, on the cavernous sinus, on, then it will start produce symptoms and he will come to us. يعني هي ليش صارت macro adenoma? ليش why the patient let it increase to this size? Because it's asymptomatic. It's non-functional. Pituitary macroadenomas most commonly are non-functional, while microadenomas most commonly are functional. If it was not functional, we would not detect it. The patient will not come. The patient will be perfectly normal, microadenoma. يعني all of us have nodules like 2 or 3 millimeter anywhere in our body. If you touch this, palpate, you will find some nodule. Here some nodule, here 2 or 3 millimeter, who cares? But if it's functional, then you'll care because you have abnormal hormones. Got it? فلا aldosterone ولا TSH ولا prolactin ولا growth hormone ولا it's non-functional and that's why it's big. So our first differential diagnosis is pituitary macro. Second, differential diagnosis of cell. By the way, what sign does that lesion present?
Snowman.
Snowman, also called waist sign, also called
Figure 8.
figure of 8 sign. So it's either figure of 8, it looks like number 8 in the coronal or even in the sagittal image, or it's snowman, it looks like a snowman. Okay, ما أعرف إذا شايفين فيلم مال فروزن إلسا هذا السنومان مالتهم ما أدري شو اسمه. Okay, or هو قلنا figure of 8 أو snowman أو waist sign, it has a waist. Okay, so this is very typical of pituitary macroadenoma. Give me more differential diagnoses of that, just for fun.
Craniopharyngioma.
Craniopharyngioma is a good differential diagnosis. What's against craniopharyngioma?
Age.
Age is not in favor of craniopharyngioma. What's the age of craniopharyngioma?
Bimodal age distribution.
Which is
5 to 10 years.
okay.
And 15 to 16. 15 to 60 years.
5 to 10 and 50 to 60.
Yes.
Okay, so it's either too small, too young, or too old. So he's in the middle. He does not fit. What else? What else? What else against craniopharyngioma?
Calcification.
It's an MRI. We don't see calcification that clearly. What else?
Craniopharyngioma mostly supracellular.
Okay,
But maybe يعني intracellular
Extend to
or
the cellular.
extension.
but this is not against. It has a supracellular component. What else? Craniopharyngioma. What's the content of craniopharyngioma?
Cystic, solid.
Cystic and solid.
Yes.
It has no cystic component.
Yes.
And the cystic component contains what?
Proteinaceous.
Proteinaceous. It's like زيت مسيرات دهن
High
مسيرات
in T1 and
شو اسمه؟ oil
Machine oil.
machine oil. It's bright on T1,
Yes.
which we don't have here.
Yes.
So this is unlikely to be craniopharyngioma. What else?
Calcification.
لا. What other differential diagnosis?
Uh,
It could be pituitary macroadenoma, could be craniopharyngioma, could be thorn-walled cyst. Thorn-walled cyst, where is it located?
in سلة راسي بارسس مو ثروة صبي فضل
Rafkis, cleft cyst.
Yes.
Okay. What else? Pituitary carcinoma. Well, it's rare, but it's possible. Good. I don't think I've seen pituitary carcinoma before. I don't remember any. Anyway, bad. Look, you have to say it. It's the nausea, vomiting, diarrhea of radiology. With pharmacology, they have nausea, vomiting, diarrhea. But radiology, we have. Come on. Could it be a meningioma? It's extra-axial. It's enhancing. It's compressing. Possible. Allah, it is not. احنا كلنا نعرف انه هاي ماكروادينوما. بس احنا بدنا نقول الديفرنشيال. What else? طيب بعد اثنين وروح الله. بعد اثنين In every mass, anywhere you say metastasis and انت تدخنين ولا سجاير؟ تدخنين سجاير؟ You don't smoke. So you don't know the types of cigarettes. أكو أنواع السجاير واحد من عندها كلش مشهور. There are certain types of cigarettes packet. One of them is very famous. It's called LM. شايف السجاير LM? Anyway, ما أعرف if your husband or anyone of your family smokes, ask him about LM. It's a good cigarette because I'm a smoker. I know that. Okay? LM. نوع من السجاير. ال N for metastasis. ال M for lymphoma. It's the nausea vomiting diarrhea of radiology. جماعة الفارماكولوجي كل شيء وجابوا nausea vomiting diarrhea, nausea vomiting diarrhea, nausea vomiting. Paracetamol, nausea vomiting diarrhea. Chemotherapy, nausea vomiting diarrhea. Radiology, we have Ellen,
Metastasis.
جدار, smoke. Lymphoma metastasis, lymphoma metastasis, lymphoma metastasis, lymphoma. تشوفين fracture femur قولي lymphoma metastasis. Always, don't forget LM. Okay? وهاي واحدة من فوائد التدريب. زين. We have time? I don't think so. بس قبل okay, so that's it for today. بس